Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Get CME for this episode by clicking on the CME link in the show notes. Today, we welcome back Huda Boumam. She is a radiology resident. Today's Kevin MD article is titled The Collaboration Between Radiologists and Clinicians for Optimal Diagnostic Outcomes. Huda, welcome back to the show.
Hi, nice to see you again, Kevin.
So we'll
Thanks
get
for
into your
having me.
article in a little bit, but for those who didn't listen to your first episode together, just briefly share your story and journey to where you are today.
Sure, yeah. My name is Huda, like you said. I did my medical school in Penn State College of Medicine in Pennsylvania. Then I did 1 year of internship in Northeast Philadelphia. And then here I am doing my radiology residency in New Jersey, Robert Wood Johnson with Rutgers University.
All right. So we talked offline that you're going into your PGY 4 year. How's radiology residency going?
Great. Loving it. Great. I mean, the workload definitely is increasing, but loving it. I'm doing a lot more overnight shift this year and the upcoming year, but it's all learning, part of the learning process.
All right. Well, tell me just some of the rewards and challenges of radiology today.
Definitely increasing the workload. There's a lot of imaging coming in, and we're reading a lot more and a lot more every day. And that's like more of the older attending saying the same thing. That's just me recently joining radiology. So we are bombarded by the load, and we also have to keep the accuracy of the reports and the diagnoses and keep, our connections with the clinical profile and everything else. So I think that's a big challenge.
So for those medical students who are listening to you, you're in the midst of your radiology residency. Tell me what kind of questions should they ask themselves if they want to consider radiology as a career today?
Actually, that's part of, I wrote this article and I'm here today because of the medical students, because as a medical student, I didn't get the presentation I wanted about radiology because it's the traditional way of presenting radiology in medical students is viewing images in complementary with pathology and anatomy and physiology. But it really is more than that. I highly encourage them to come down to the reading room and shadow with us and talk to us and have an actual like real time rotation with us to see that we do a lot more than just interpreting images, and the interpretation of images itself includes a lot more than just viewing the image and writing a report of what it could be or giving a differential diagnosis. There's a lot we consider. We may need to talk to the clinician. We may need to go into the chart and read about the history, read about the personal family history, gather a bit more information about the lab values of that day to kind of give the most appropriate diagnosis, or if not, what's the highest on the list of the differential diagnosis. So there's a little bit more involvement than what is traditionally presented to medical students about radiology. There's a little bit more involvement, and I know it is very challenging with what I just told you, with the increase of the load and having a medical student with you. It's challenging, but it's definitely doable. And I highly encourage them to be active in the rotation and ask questions. And, we're all friendly, and we love to have future radiologists with us that are dedicated and engaged. So we love to engage them as best as we can.
All right. So let's talk more about that Kevin MD article is titled The Collaboration Between Radiologists and Clinicians for Optimal Diagnostic Outcomes. See if we could clear up some of these misperceptions here. So tell us, how did it come together?
Like I said, the traditional definition of diagnostic radiology as interpretation of images and given a list of a differential diagnosis, I thought it needed to come an end, and someone needed to come, whether write about it or speak about it, that we do a lot more than that. Our work, our daily routine involves a lot more than just giving the clinicians a report. It's a close kinship with the clinicians. We can't do our work without them, and they can't do their work without us. So in a big hospital, a tertiary hospital, we are constantly on the phone with the clinicians, and they're constantly in our reading room discussing cases, talking about potential diagnosis and what could, because not every case is a bread and butter, like, acute appendicitis or something that's very easy. Some cases are very challenging, and we need each other. We need every taught to kind of get the optimal or the best diagnosis possible. So that's why I wanted to write this article to define radiology a little bit more closer to what it actually is. We are involved in patient safety. We are involved in protocoling studies. Many clinicians call us before ordering a certain study. They give us the clinical scenario and they ask us, well, what's the appropriate study? Do we need contrast? Do we need oral contrast? Do we need intravenous contrast? And all we are involved in all of this. We are just not only reading images.
Mhm.
That's why I wanted to write an article or speak about it and kind of tell medical students who are interested in radiology that it's more than what is traditionally advertised, and tell the clinicians who are not necessarily in close kinship with the radiologist that we do more than that.
So tell us a story, case study, or example where that collaboration with clinicians led to a positive patient outcome or made a difference in the patient's diagnostic course.
I mean, all the time. Like, I can share one with you. When I was reading out with my neuroradiology attending a brain MRI, and we read it as normal brain MRI. And the neuro team came down right at the time where we were reading out that case. And there was a very subtle finding that we missed initially. But when they came to us and they presented the patient, we went back and we looked. And it was a very, very subtle acute infarction
Mm.
that, based on that presentation, we could figure it out when we went back and looked. It was very, very small dot that you can very easily miss. But because they came and they presented the clinical picture of the symptoms of the patient, we went back and we read it and it was true. There was a very, very small acute infarction. So that's a very, very small example that came to my mind as you asked. And we have plenty of examples every day like that. So that's why it's very important to give us the clinical picture, and very important for the radiologists too, that if they are not sure why the study is being done, to give that extra call or go to the chart and look for extra information.
So, when it comes to that clinical information that radiologists need to do their jobs to the best of their ability, exactly what type of information would be most helpful for us to give to you?
So it depends on the study. If it's like, for example, an abdomen and pelvis, and the clinical indication says abdominal pain, but you see a lot more than that. For example, you see lymphadenopathy everywhere. It's probably there's more than abdominal pain. Maybe there's cancer involved. Maybe there is some infection that's like more involved. So when there's merely abdominal pain and you see a lot more radiographic findings, it's got to be something more than that. So you either call the clinician or look for more information in the chart if it's available. I understand that not all practices have a chart available for every patient. It depends again on the practices. I'm very fortunate to be in a big hospital where I have access to the patient chart. I have access to their clinicians. I can call anytime. They can come down to the reading room. So I'm lucky in that sort. So I have no problem with that.
So, tell us how the field of radiology has been changing. So,
So
give us an example of how AI intersects with radiology. Are you using it to help transcribe? Tell us what are some examples of some AI tools that you would use to increase efficiency in radiology?
I
What would be an example of that?
it would be the one that I see used the most. Is with the strokes. When a stroke patient comes in, there is a something, and it's called Rapid, where it picks a possible, what we call it, a possible occlusion, a vascular occlusion, or a stenosis in that area. So it highlights it in a color. So it tells you, oh, maybe there's something there. Sometimes it's right and sometimes it's wrong. That's why you definitely need a radiologist to go back and kind of go through all the vessels and make sure there is or isn't an occlusion. But that's the one thing. So it rapidly tells you, oh, maybe you'll need to look at that area specifically. There might be something there occluded or a stenosed at least.
We're talking to Huda Bouam. She is a radiology resident. Her Kevin MD article is titled "The Collaboration Between Radiologists and Clinicians for Optimal Diagnostic Outcomes." Huda, so let's get back to that relationship between radiologists and clinicians. What are some red flags? What are some things that we on the clinician side should not do when it comes to interacting with radiologists?
You should not ignore that your importance, your hand in our hand when it comes to, because there is a patient. Both you and I have a goal of giving the optimal care to that patient. I am going to share a very small story that I had when I was training in the Senegal as a fourth year medical student. I did a global rotation, and I didn't know much about radiology at the time, but I did witness a very tense conversation between a radiologist and a gastroenterologist, and where a radiologist refused to read a scan because she said she didn't have adequate clinical information. At the time, I didn't understand that. I just questioned myself, why did the radiologist have that reaction? She just said, I don't have adequate clinical information. I see radiographic findings here, but I can't give you an impression. Basically, that's what she said. And she left. She didn't read the scan. And then I left and I didn't understand anything about that conversation. But then in my head, I was like, why did the radiologist react to that like that? She just could have just reported the scan and then the day would be over. But then going into radiology and understanding what it encompasses and the impact we have on patient care, I understood the importance of having the full patient profile, and the importance of having the background to write your impression and tell because you want to be helpful. You just don't want to have a template and fill in, all your organs, what's normal and what's not. The patient, it's not a matter of entities. You have to look at it as one thing, and we have to get together to do that. That's my main point, is getting together, because medicine, no one can do medicine alone. That's what we've been taught in medicine. It's all like, a team-based, we all do it together. And that's what radiology is.
And my final question, tell us some of your take-home messages that you want to leave with the Kevin MD audience.
I want my medical students to please come rotate with us, try to have a feel of radiology. It's more than what is given to you traditionally in medical school. We're a lot more involved in patient care, sometimes directly in patient care. We talk to patients. We discuss their safety in terms of contrast, giving them contrast reactions. We do deal with those, and also like healthcare systems and insurances. We're aware of all that, and we discuss that too in our daily basis. And my second message is to the clinicians, again, to have that collaboration, to work with us, even outpatient settings, to call us when you don't understand the radiographic finding, to call us when you feel like the report does not match the clinical picture. If you're suspicious of something, even if you get the final report and still have a suspicion, call us back. And to my radiologist, call the clinicians when you need information, when you feel like you have a gap that's missing, and let's get that kinship going for the best of our patients.
Huda, thank you so much for coming back on the show, sharing your time and insight.
Yes, of course. Thanks for having me, Kevin.